was to provide protections to enable providers, healthcare professionals, to be able to share information and talk with each other about harm, errors, what keeps them up at night, ways that we think we could do a better job, all within a culture of safety, so that we could share this very sensitive information without fear of litigation or harm to professional reputation. And the IOM, in its landmark report in 1990 to Err is Human, pointed out that, you know, if we could just allow healthcare providers to talk to each other and share information, then we could allow improvement to occur throughout the healthcare system, and that errors that we're seeing in one hospital wouldn't, or healthcare provider facility, would not occur over and over and over again throughout the healthcare system. And so the goal of this act is to improve quality, reduce errors, and save lives, as well as reduce the healthcare costs associated with errors and that happens with improved care. Next slide, please. A patient safety organization is typically a separate organization whose mission is to improve patient safety and quality of health care. Patient safety organizations have many different types of programs. Generally, the patient safety organization is an organization of experts that have the ability to collect information that would accelerate the identification of specific harms, and also would have the expertise and the analytic capability to understand what is happening and produce evidence-based solutions and best practices in order to prevent the harm. Oversight of patient safety organizations is done by the Center for Quality Improvement and Patient Safety at the Agency for Healthcare Research and Quality, AHRQ. And PSOs work with providers throughout the healthcare continuum. So we have PSOs that focus and work with providers in EMS, in pharmacy, in clinics, ambulatory care, inpatient services, hospitals, long-term care, rehab. We have PSOs that specialize in specialty care, such as anesthesiology and vascular services. And in each of these different, along the healthcare continuum, they use different health IT systems in providing patient care. And so these PSOs have a great understanding of the work that the providers perform, but in addition to that, they also know the health IT systems and the interfaces. In this way, they're able to evaluate and work with the providers and the HIT developers to improve care, solve problems, unintended consequences. Next slide, please. So patient safety organizations can encourage a safety culture because Congress provided several different types of protections that not only protect the data, and we call that patient safety work product, the protected information, but also there are confidentiality protections to protect the provider. Because providers said, you know, you can give us all the privilege protections that you want to, but unless we have confidentiality, we're not going to make the reports, because there's always that potential for our professional reputations to be harmed. And so Congress gave really three protections. First, the privilege for the patient safety work product, and the privilege is very broad. The information that is produced and by the providers and reported to the patient safety organization, and that's developed by the patient safety organization, all the conversations, analysis, and deliberations are not subject to subpoena, discovery, or admission into evidence. They cannot be used in any type of state disciplinary proceedings. And there are extra protections that we've never had before. For example, the privilege and confidentiality protections cross across state lines, so it blankets the 50 states as well as the territories that are among the United States. And so patient safety organizations and providers are able to share information across state lines to create learning systems. And so, for example, we have many health systems that have hospitals that cross state lines, and before the passage of the Act, they would not be able to share information about different events that occurred across state lines. And so that produced the anomalous results that errors, the same type of errors, could be occurring within the hospital system, but just in different parts of the country. So this Act relieved that, and it now allows learning systems to be developed so that information can be shared not only just hospital to hospital among systems, but also unrelated, unaffiliated hospitals and other providers throughout the entire United States and throughout the healthcare continuum. The Act also establishes federal peer privilege protections for all providers, and so we're seeing some really exciting programs where we're having peer review happen in ambulatory care, for example, in the states that did not have peer review for pharmacy or EMS. We now can see those type of programs popping up as well. So it's really exciting to see all of the programs that are really tailored to improve patient care. The confidentiality protections are very similar to HIPAA. So we have privacy for providers as well as for patients, and there are civil money penalties against any person who discloses this confidential information with the provider's names identified. The third type of protection is a very new protection that we've never really seen before, and that is that the PSO has protections for information that providers give to them. The patient safety work product are protected information, and also information that they develop and return back to providers and share with providers. And the reason for that is that Congress recognized that we had to have faith and trust in an organization that we're giving very sensitive information to. And so because of this, they determined that information would have to be obtained through other means and not through the patient safety organizations. Next slide, please. So just take a step back, looking at the current practice without the PSO protections, typically what we see is that errors or incidents could be reported through the QI or risk management system of a hospital. The hospital would identify and analyze problems, collect and analyze information. They create and implement corrective actions and identify and address trends. But the problem was all of this information would stay within the four walls of a single hospital and would not be shared throughout the healthcare continuum. Next slide, please. So the goal of patient safety organizations is to allow the providers to break that silo and to promote transparency throughout the healthcare continuum by giving them the ability to share case studies and best practices with healthcare entities, with healthcare professionals, with patients and consumers to improve patient care. And Congress intended for us to be able to share all of these best practices, clinical protocols, solutions throughout the healthcare continuum as a way that we can raise the quality and the baseline for all providers so that we would raise all boats and learn from each other rather than having each individual provider go through the process of learning by their own mistakes. Next slide, please. So the PSO is a very innovative model. The purpose of the Act was to be very flexible and to allow providers and experts to develop all different kinds of programs to address and improve patient safety and quality of care in new and exciting ways. And we're seeing very exciting programs being developed in the area of HIT quality, and we're going to share some of those programs and investigations. But first, next slide, please. We're going to take a step back and look at how did we get here. The investigation really started by the Institute of Medicine in 2011 in their report, Health IT and Patient Safety, Building Safer Systems for Safer Care. And what they found when they looked at all the evidence that was available after the adoption of Health IT was supported through the HITECH Act was that with the speed of the implementation, that we really haven't had an opportunity to evaluate the full potential of Health IT on patient safety, and that we really needed to collect information and get a better understanding of the impacts, potential harms, workflow, and other considerations that we might be missing or not seeing, unintended consequences, for example. And in their report, they made multiple recommendations, but at the end of the day, they said, you know, if we're not going to be spending new money, that PSOs probably are the best option for collecting this information from healthcare providers and working throughout the continuum and with healthcare HIT developers to solve any problems or improve patient care. Next slide, please. In 2013, the Office of the National Coordinator issued its HIT Patient Safety Action and Surveillance Plan. And in that report, they also supported the use of patient safety organizations to meet two core objectives, and that is to use health information technology to make patient care safer, and also to continuously improve the safety of health information technology. And we're going to be talking about and using several examples of PSOs' work to show both how PSOs are making recommendations for HIT to make care safer and also to continuously improve the utilization and the safety of HIT, or the quality of HIT, really. Finally, in 2014, last year, the Food and Drug Administration led an activity that was congressionally mandated through the FDASIA legislation, and they issued a report that also supported the use of patient safety organizations to work with providers to improve the quality of HIT, and also look at implementation issues and usability. And also they have recommended establishing a Health IT Safety Center. So there's been recognition by multiple experts as well as regulatory bodies that PSOs, because of their expertise and because of the protections that we are given under the Patient Safety Quality Improvement Act, are probably the best tools to ensure continuous quality improvement with the use of health information technology in healthcare. Next slide. So we're going to talk about a few examples of patient safety organizations' activities in relationship to health information technology. The first example was provided by AMC PSO, and they're a component PSO of the Risk Management Foundation of the Harvard Medical Institutions. And they've been doing some really interesting work bringing experts together in a safety culture to solve problems. And these are called convenings. And they analyze data and identify best practices and other means to reduce risks and hazards associated with patient care. And they've really been doing some amazing work in the health information technology space. Next slide. So as an example, they took a look at electronic test results management, and they convened key leaders and experts to address issues in test results management. 25% of all outpatient medical errors can be attributed to the test result follow-up process. Diagnostic test volume is increasing, and clinicians estimate that they receive 1,000 results a week, and that has produced overload. And in some cases, some of the test results fall through the cracks. So AMC PSO conducted a very thorough investigation to identify the risks associated with electronic test results management, and they identified an extensive risk list, and then they took those risks and analyzed them, and through their experts they developed recommendations for improved management in the electronic health records. And so they found that the systems have been very effective to reduce delays and decrease the incomplete follow-ups, but still there was work that needed to be done in integrating the technology with the routine clinical workflow. And they created a series of recommendations and shared these with healthcare providers and EHR developers as well as the healthcare community to improve the test management so that care would be improved and the tests could not fall through the cracks. A second example of how PSOs work to continuously improve the quality of HIT, next slide please, has been performed by the Alliance for Patient Medication Safety, and they're a component patient safety organization of the National Alliance of State Pharmacy Associations. APMS's mission is to foster continuous quality improvement in pharmacy. And next slide please. They, in 2010, established a portal where any pharmacist could report their e-prescribing experiences and challenges. And so their goal in providing this portal was to improve the quality and effectiveness of electronic prescribing technologies. They wanted to identify whether pharmacists were having problems with e-prescribing, and they did this through a standardized worksheet. And they also wanted to estimate the financial impact, the time spent, how long does it take to resolve any type of issues in e-prescribing, and then develop recommendations for possible solutions. They were funded through many different sources, and in 2011 they published the results, and it proved to be a very successful tool to be used to report e-prescribing events and information. Next slide, please. So this is just a snapshot of some of the results that they collected. They found that the majority of the reports involved problems with prescription abbreviations, such as 2 times per day, only at bedtime, and also the directions and the quantity selections. Most of the incidents that were reported were near misses, and that means that the problems were caught by the pharmacists in quality verification processes, and so most of the misinformation did not reach the patient. And the average time that it elapsed to resolve the e-prescribing incidents was over 8 hours. And so this was useful information that was used to develop best practices to help improve the systems. So next slide, please. So at this point in time, they're creating a new initiative where they would like to, they're reopening the portal to collect the same information and see what has happened, what has happened with the experience between 2012 to today, and to examine the relationship with the types of errors and work with stakeholders and produce recommendations for procedural changes that can prevent prescription errors in the future. Next slide, please. So these are really examples of how PSOs are working with providers and health information technology vendors to improve patient care through the use of health IT, and also to have a process for continuous quality improvement. And the relationship is a shared responsibility through all within the healthcare system, and that is because providers can uncover potential issues or unintended consequences, and they also, through the RCA process, typically can discern how HIT can make healthcare safer. For example, there might be an error that occurs, and we take a step back and say, if only we had modified or had the vendor modify the HIT system, this couldn't have happened. And so that's one of the goals that we have in working with our providers to identify those moments. The health information technology developers understand how their technology works. And so they are very, very helpful in working with PSOs and providers to understand how things can happen or how we can change the systems to make care safer in coding and other things that the providers would never have the expertise to do so. And so when we bring providers and developers together under the protections of the PSO and with PSO experts, we can collaborate to improve the workflows, the systems, the interfaces, interoperability, and quality of patient care and save lives. Next slide, please. So this last slide is just a nugget of knowledge from IOM from their report to Error is Human from 1999. And I think that they were very, very wise in saying that mistakes can best be prevented by designing the healthcare system at all levels to make it safer and to make it harder for people to do something wrong and easier for them to do it right. So with that, I'd like to thank you for listening into my portion of the presentation and hand things back.
Great. Thank you very much, Peggy. As we transition to the next presenter, I just wanted to remind folks that if you put a question to the speakers, if you can identify which speaker you'd like to address your question, that'll be helpful. If you don't, then you know, they'll take their pick, or maybe more than one will answer. And then the other thing is just a reminder that these slides will be available after the webinar is finished, in case people were looking for handouts. The next speaker is Ronnie Solomon, who serves as Executive Vice President and General Counsel at ECRI Institute, and has overall responsibility for their legal affairs, their healthcare safety, their risk and quality initiatives. And she's been working in this area for 20 years, doing healthcare law, risk management, and patient safety. She's a member of the executive team there, and she really has developed and led many of their initiatives for public and private sectors on patient safety and quality of care, including ECRI's PSO, which is a federally certified patient safety organization. So Ronnie will be talking about the evidence from PSOs on improvement, and I'd like to now introduce Ronnie Solomon.
Thanks very much, John. And you know, actually at this point it's been 30 years, and of course I started when I was 6 years old in all of this. Anyhow, I've got a lot of slides to get through on partnering on health IT patient safety, and of course they're all about improving safety and avoiding harm. So hopefully this won't be death by PowerPoint, which I understand is one of the biggest causes of death now in the country. But anyhow, we all know that health IT has enormous potential to make care safer when it's designed and implemented and used appropriately. And we've seen that it can reduce medication errors, it can help us share information, it's helped get rid of illegible handwriting, and much more. There's been some really innovative work being done on sepsis prevention and how you can use the EHR to accelerate that work. But like any new technology, there are potential hazards. There are new potential hazards. They're emerging. They're evolving. You know, X-rays let us see things that we never saw before. The automobile let us go places that we never went before. Do they have risks? Yes. Have we learned to manage them? Yes. So we're at that place now where we need to understand and mitigate the risks of HIT so that it can fulfill its incredible promise. And why is that so important now? Well, really, the adoption of health IT has skyrocketed. There's probably been more than a 5-fold increase since 2008. And with this rapid spread, we really need to keep a watchful eye on emerging patient safety issues.
Ronnie, this is John. Can you just let us know when to advance the slides?
Yeah. Will do, I promise. So we know that HIT can have widespread impact. An unsafe configuration can impact many patients, and if the safety issue is difficult to detect, then the risk gets higher. So look at the slide that you've got in front of you now. Do you think your EHR or the way it's used has been associated with adverse events in your organization? For the next couple of minutes, I want to share some cases with you. And as I do, think about two things. First off, do you think that it's an HIT event? And second, would you want to report it to a PSO or a safety center, like Peggy just has been talking about? So next slide. So here's case study 1. On admission, the patient's weight was documented as 40 kilograms, but the patient actually weighed 40 pounds. The EHR allows the patient's weight to be entered in kilograms or pounds. The patient's medication dose was based on weight in kilograms. Pharmacy caught the error, so it was a near miss, and they corrected the dose based on the patient's true weight. What do you think? Is that an HIT issue? Would you report it internally? Would you report it to a PSO? Would you report it to a patient safety center? Next slide. Case study 2. The surgeon tried to access a patient's radiology study from the PAC system in the OR, but the display would only show a blue screen. And as a result, the patient's time under anesthesia was extended in order to get the computer display to work. HIT issue? Would you report it? Next slide. A physician ordered extended release morphine every 12 hours to control pain. But there was also an order for a smaller dose of immediate release medication for breakthrough pain. The patient complained of pain, ended up got both doses, and went into respiratory arrest. The investigation showed that the EMR system truncated the display so the providers could not view information on the various formulations. HIT issue? Would you report it? Next slide. The provider begins to enter medication dose and types in 1010 for a 10 milligram dose. A highlighted list appears, and the software auto-selected 100. The provider selected the highlighted dose, which of course was 100 instead of 10. Is this an HIT event? Would you report it? Next slide. The provider enters a medication order and a lab order in the free text fields of the EHR. Is this an HIT event? Would you report it? Next slide. The medication management system allows the pharmacist to navigate off of one patient profile and pull up another patient profile. An incorrect medication order was placed in the wrong patient's profile, and the patient received incorrect meds as a result. HIT issue? Would you report it? Next slide. So there's some examples of what we see, and they're all events that we received over time. And Peggy mentioned some of the seminal work that's going on. So you can see on this slide that on your left in orange is the IOM report that was released, I believe, at the end of 2011. And then in the middle is the ONC's Patient Safety Action and Surveillance Plan. And then to your right is the FDASIA Health IT report, which was issued by ONC, FDA, and FCC, and discusses a risk-based framework for HIT safety. Now, all of these reports recognize the extraordinary benefits that HIT can bring, but they also recognize the potential safety issues. And they called for action by both the public and private sectors. And as both Peggy and Jonathan have mentioned, the ONC has requested funding for a Health IT Safety Center. RTI is actually working on the roadmap for how that center might work. Next slide, please. So with this rapid adoption and with this federal spotlight on HIT safety, at ECRI Institute we decided to take a look at the data that we're getting. And as many of you may know, we've run patient safety programs for decades. Some of them are big, some of them are small, some of them are voluntary, some of them are mandatory. Some are our own, some we run under contract with others. And through ECRI Institute PSO, we work with many other PSOs, and we work with more than 1,000 hospitals and many, many other types of providers. Over the years, we've probably received over 4 million reports of adverse events and near misses and RCAs and hazards. So what you see on these slides are 4 resources that are available to you. They are analyses and guidance documents based on what we've done when we did a deep dive into the adverse events and near misses that have been submitted to us. So on your left is a report in 2012 that was published by the Patient Safety Authority, and it involved an exploratory analysis of over 3,000 HIT-related events submitted to a statewide reporting event. The denominator was well over 1 million events, but we ferreted out over 3,000 HIT-related ones. The second report is a deep dive analysis on a very small subset of reports submitted to ECRI Institute PSO, but we did that deep dive and looked at them very, very carefully. The third document is a report that we did for the ONC that had been based on this previous work. It's up on the ONC website. It's got some good information for you. It's got a slide deck in there so you can use it or adapt it for your organization. And then the final document on the right is a top 10 hazard list. And every year, ECRI Institute publishes a list of technology-related issues, and Health IT has been on that list for a couple of years. We have 2 more reports that are about to be released. I'm happy to share them with anybody who wants them. I think there's one coming out in, I think, a couple of weeks on wrong record, wrong data errors, and then another one that looks at the potential for EHRs and how they can be used to improve safety and quality. Next slide, please. Now, one thing we learned from our deep dive is that frontline reporters often fail to report events as HIT events or fail to report them as HIT related. They might not even realize or recognize that HIT played a role in an adverse event. So they might get reported, for example, as a medication error or a diagnostic error or a surgical error, but not necessarily an HIT issue. Next slide. What did we see as the top 5 events? Most of the problems were at the human-computer interface or in the human side of the equation. We continue to see problems that happen back with the paper chart. So, for example, entering incorrect data, entering data in the wrong chart, failing to enter data, failing to update earlier entries. Those sorts of problems have existed for a long time, and they haven't been solved by the electronic health record. We also see software configuration problems and interface issues. Is the system firing off the right drug interaction alert? When that library is updated, are the alerts updated? Those sorts of things. Next slide, please. This slide is from our top 10 health tech hazards from 2015. And they're not just about health IT, but they cover all sorts of technology-related safety issues. But this year, number 2 on the list is data integrity, incorrect or missing data in EHRs and other health IT systems. And the reason this got on the list is because what gets troubling is that once inaccurate data gets into a record, it's really hard to spot it and correct it and get it out. And when a problem is hard to detect, the risks get higher because busy professionals can overlook them. Next slide, please. So what do we know? We certainly know that reporting HIT events is important. They contain gems for learning. And this is especially important as a new technology becomes widely adopted and it evolves and it's implemented in various ways across many, many settings. So we really need to communicate events internally as well as externally. But before we can share them, we need to recognize them. And it sounds easy, but it's not necessarily so easy because, as I said, the frontline staff might fail to recognize that HIT played a role in the event. So remember that case study earlier on that I mentioned in which the pharmacist placed the medication order on the wrong patient's profile. We've seen those events time and time again, but they're labeled as medication errors, not necessarily HIT-related events. And our team has to ferret out that information and classify them as HIT-related events. So what we do know is that we're not going to be able to fix things unless we fully understand why they happen, and we won't be able to fix them until all stakeholders until all the stakeholders collaborate on this issue. This is really a shared responsibility. Next slide, please. So knowing that HIT is a complex issue and that there is shared responsibility, we convened in early 2014 the Partnership for Health IT Patient Safety. And we convened it so that all stakeholders could work together. We know that HIT safety issues are multifactorial. They're not just a user mistake. They're not just a product malfunction. They often involve usability. They often involve the way in which the technology was implemented. It's really part of a broader system. And sometimes I use the analogy of highway safety. It's not just the car. It's not just the driver. It's the signage. It's the roadways. It's the seat belts. You know, it's even the weather and the potholes. I can tell you that because of my ride into work this morning. So HIT involves behavioral change. It involves industry change. It's really a shared responsibility. Next slide, please. So these are the groups that are working on the Partnership for Health IT Patient Safety. If you just go back one. So you can see it's different associations, it's academic researchers, it's many healthcare organizations, and it's the vendors. So we're all working on this together, also many PSOs. Next slide. The purpose of the partnership, making health IT safer together. You can see what our objectives is. Their objectives are, they're pretty straightforward. As Peggy mentioned, one of the real goals is to establish a non-punitive environment for sharing and learning. It's got to be non-punitive or people don't want to participate. And then we're testing this collaborative model for collecting and analyzing safety issues, achieving robust stakeholder engagement, sharing best practices and lessons learned. We're using reporting taxonomies, which are always tricky. And ultimately, we want to be able to inform the national strategy for health IT safety. Next slide, please. Here's the approach. There's three big buckets that we work on. And one is just getting the data into the partnership. And we've been really successful with that. And we're getting all kinds of data, things that we expected, like adverse events and near misses and hazards, root cause analyses. But then we're getting some things that we didn't expect, like, alerts that have been issued inside of an institution, and even, thousands and thousands of help desk tickets that, get created within institutions. And then once we get that data, we've got to make sense of it. So, of course, there's the analytic piece, and then using it, and this is the most important piece, for leveraging learning. Next slide, please. So what are these word clouds you're looking at? In September of last year, the partnership held a face-to-face meeting, and the theme was Partnering for Success. And really what was important about that meeting was to establish a trusted place for exchanging important safety information. And all of the stakeholders were there. So again, it was a multi-stakeholder group. It was oftentimes people who aren't necessarily sitting in the same room to work on things together. And that's what we wanted to establish, a place to share and learn. But to get this diverse group to talk, we really started out with some anonymous polling, and you can see the results here. So at the beginning of the day, we said, what do you see as the top HIT safety issues? And you can see on the left-hand side that the cloud is really pretty busy, and there's lots of issues in there, and probably not much agreement. And at the end of the day, we asked the same question, and you can see that there was more clarity and more agreement about what we all need to work on to be able to take some giant leaps forward. Next slide, please. One of the things that was decided at that September meeting is that the partnership needed to have some topic-specific work groups to focus on specific problems. And after a voting process and lots of vetting, we ended up choosing as a first work group the issue of cut and paste, copy and paste. It's not that we're trying to be radical about this. The goal is not to eliminate cut and paste, but it's to really understand the unsafe aspects of copy and paste, and again to consider those behavioral as well as industry changes. The work group has already convened. It's meeting monthly. They expect to issue best practices this summer. And again, it's a multi-stakeholder group, so there's participation from several of the EHR vendors, as well as providers and academic researchers and patient safety organizations. The chair is Dr. Tejal Gandhi, who is the president and CEO of the National Patient Safety Foundation. So we're off to a good start. And of course, we all know some of the risks associated with copy and paste. There's good stuff, but there are risks. Copying information into the wrong record, using inaccurate or outdated information, redundant information, lots of note flows, inability to identify the author, and so on and so forth. So we're going to be studying those. We've commissioned and we'll be using an evidence report to help inform the work group. We're pulling out data from the partnership to help inform the work group. The journey has begun. Next slide, please. So here are the next steps very quickly for 2015. We've published the results. We've published the proceedings from the September meeting. You can get them. They're freely available. I mentioned the work group and that we intend to disseminate best practices. Next slide. I want to mention some fantastic work that's been done by Dean Siddig and Hardeep Singh. If you're involved in HIT safety, you probably know those names. And this is something that you can do right now, which is to really adopt this systems thinking, this what they call the socio-technical model of safe and effective health IT use. And it's so important that we have systems to identify events internally and to share them. But then a good way to design effective solutions is by using that socio-technical model developed by Siddig and Singh. And you can see the 8 dimensions on this graphic. And really, just one key point I want to make. These 8 dimensions are not independent. They're not sequential. They're not hierarchical. They're interdependent. They're interrelated concepts, similar to compositions of other complex adaptive systems. So again, like with highway safety, we need good cars, we need good drivers, we need good roads, we need good signage, good maps, and good regulation and policy to drive the right outcome. It all interrelates. The same thing with health IT safety. It's a safety system, not just a user issue, not just a product issue. So I have concluded my comments, and I think I'm right on time. So thank you, John.
Great. Thanks very much, Ronnie. And can we go to the next slide, please? Okay, great. Next slide. Okay. Our third presenter today is Drew Ladner, President and CEO of Pascal Metrics, which is a PSO that serves a large community of healthcare systems and stewards some of the large patient safety data sets. Drew is a pioneer and innovator in patient safety and health IT. Pascal was the first PSO to be certified and successfully audited to use real-time clinical data to identify, track, and manage all-cause harm. Drew holds an MBA from Harvard Business School and an MA in Theology from University of Oxford and a BSSS in International Economics from Georgetown. And he will be presenting on sustainable system-wide safety, enabling PSOs to improve patient safety in a value-driven environment. On to you, Drew.
Thanks, John. following up on Peggy's rich overview of PSOs and their role, and Ronnie's helpful example of ECRI and their work, what I'm going to do is to share what we at Pascal see as significant opportunity in the field to use real-time clinical data to identify, track, and manage patient harm. Moreover, from our perspective, the imperative of improving patient safety, amplified by recent findings that 1 out of 3 patients suffers an adverse event while in U.S. hospitals, is complicated by the rapid adoption of EMRs and other health IT, a challenge that's been affirmed by the landmark IOM report on health IT and patient safety that Ronnie also cited. So today, we're going to try to explore how to turn the tables, the opportunity to use health IT while posing risk, and specifically real-time health IT to actually make patients safer. Next slide, please, Stephanie. So what we'll do is quickly walk through recent literature and studies showing harm is far higher than was previously thought, that PSOs are intended to be part of the solution, opportunities that have recently emerged for PSOs, how health IT helps PSOs take advantage of those opportunities, how real-time PSOs work, which is a subset of that further, and how they drive improvement, and then also the findings that are emerging indicating that there's a business model, that in fact PSOs using this type of approach can prove to be even more self-sustaining from an economic perspective. And then finally, just some thoughts as we conclude on where we see PSOs heading in the future. Next slide, please. So let's start with the data, data that has repeatedly astounded the field as study after study has come to the fore. First, we all know that there was significant interest 10 years after the off-cited IOM to ERA's human report on how much safety had improved. After all, there had been a lot of investment in patient safety, and so researchers went to a number of states that had actually invested more than others, hoping to find significant improvement. What researchers found instead is that not only had patient safety not improved as much as had been hoped, but it actually worsened. And according to a Health Affairs article in 2011, actually the most downloaded one that year for Health Affairs, adverse events likely were 10 times worse than previously thought. Further, the Department of Health and Human Services Office of Inspector General affirmed this conclusion and others with its own study, finding that trigger-based review detected both never events as well as HACs, hospital-acquired conditions, not identified by event reporting, and later that voluntary event reporting identified approximately 1% of the patient harm suffered. In another study that was much discussed, Baylor Healthcare System, in a widely cited study, showed great transparency in publishing rates of harm using the IHI Global Trigger Tool, which, along with other studies that we've cited, as well as others we haven't, was found to be quite effective in identifying patient harm. Furthermore, Baylor's experience also began to cast light on the magnitude of costs associated with patient harm. Next. In the Health Affairs article written by lead author Dr. David Klassen and a colleague, the clinical trigger-based approach of the Global Trigger Tool proved to be 10 times more effective than the patient safety indicators in identifying adverse events, and almost 100 times more effective than voluntary event reporting. In sum, the data suggested that we simply needed to take advantage of more tools. This data, along with the experience of other academic clinicians in researching the measurement of harm, began to precipitate questions in the safety and quality community. One was, if clinical triggers were effective in identifying harm, how might we move beyond improving the measurement of harm to actually intervening to reduce harm, and with that, related costs? Next slide. So before we move to that question, let's just review what the role of PSOs is. We won't spend time on what the law firms, since I think Peggy and Ronnie have done that. But it is important to point out that as we begin to detect far more harm and related costs due to the use of health IT, let's say in a real-time environment, the role of the PSO will become ever more important in protecting that culture of safety, which my colleagues today have talked about already. And that's critical to encourage caregivers to continue to detect harm, which then enables the provision of feedback in a culture of safety that clearly the PSO is intended to provide. Next. Besides the law, clearly policy has also weighed in, and one of the recommendations in the IOM report on health IT and patient safety certainly indicated that the PSOs occupy a central role in patient safety learning and improvement. Next slide. So it is really on those functions that the PSOs have focused in the first generation. And as we move into what we might consider the second generation of the patient safety organization, that is in the age of health IT, a range of opportunities has emerged for the PSO to play a role. And next, first of all, how do we tap into a range of data types? Next. Second, how do we use data concurrently as care is delivered? Next. If there is cost associated with harm, how do we show the economic self-sustainability of patient safety programs in an even more compelling way? And even looking to safety issues contributing to margin in a value-driven environment. Next. And then as we, all of us, I think, are hearing more and more about predictive analytics, which has been used very effectively in other industries, how do we benefit in patient safety? Next. And then if we are going to use these methods to learn, how do we actually improve the speed of our learning and the efficacy of the learning? So finding satisfactory answers to these questions would have been challenging 5 years ago, probably unthinkable for many 10 years ago, but now there's a lot of promise as the community comes together to figure out how we move swiftly into the age of health IT and patient safety. Next. So one of the key shifts in the PSO model that we see happening has been enabled by health IT. Next. Because historically, the mental model for many with respect to the PSO has been a metaphor of a library where there's a central repository of information. And researchers study that information retrospectively to generate insight. Next. 10 years after the passage of the Patient Safety Act, however, the model is shifting and shifting very rapidly, whether we accept it or not. We now live in a world where the more apt metaphor might be a control tower, which provides that valuable function, amongst others, of in real time identifying, tracking, and managing potential safety problems in a highly complex system, in our case of healthcare, in order to avoid defects and ensure that in a control tower context, passengers arrive safely. In our context in healthcare, that patients are kept safe. Why has this happened? Ronnie mentioned it. I mean, EHR penetration over about a 5-year period has moved from less than 20% to over 80%, which kind of roughly mirrors the period since the PSO rule was released. This is a tectonic shift. And add to that the scale of investment in EHRs and other health IT, the expectations of patients and their families, providers, payers, and even the regulators will continue to increase. So how do we address that? That is a key question. The availability of real-time clinical data, we believe, is a big answer in that, or to that question, and that will make measurement, monitoring, and intervention possible. Next. So to be clear, it's not all about the technology. It's also understanding, as Ronnie indicated, that we are dealing with socio-technical systems, and we have to appreciate that as we seek to improve the safety and reliability of care. The IOM made this very clear in their report mentioned earlier, and as we look at the 5 components of the socio-technical system, at the center of this Venn diagram is what is the core of all of this, which is culture. So our journey at Pascal started with culture, measuring culture, using culture for improvement, and that continues because culture is core to health IT and patient safety. And actually, I'm also delighted to share today that to that end, Pascal and the University of Texas Center for Healthcare Quality and Safety are partnering to contribute to the field in this area because we see this as critical to the field's evolution going forward. And so we have a patient safety culture database of about 40,000 units worth of data. So to that, what we'll be doing is adding EHR-related safety culture data based on an EHR safety culture survey that was created by Dr. Dean Sittig and Dr. Eric Thomas and their other colleagues. And this will provide a scientific foundation for defining and measuring a culture of patient safety related to the implementation and use of EHRs within as well as across healthcare organization. So what we're seeking to do is to figure out how do health IT and patient safety work together and really begin to add more data to this question so we can improve patient safety as a result. Next slide. Certainly, for those of you who have followed the importance of culture, it's no news that culture, in fact, predicts outcomes clinically, financially, operationally. And again, what we want to do is not only use that data, but add to that other novel survey data, as just mentioned, as well as clinical data, even real-time clinical data next. So as we move from the library model, if you will, to the control tower model, how does a real-time PSO work? How does a PSO use real-time data? Let me just describe this briefly to give a concept of how it does. So in short, a PSO ingresses data in real time with HL7 interfaces and other interfaces into a cloud-based service or other service. Then business rules and potentially more complex algorithms can be used against 100% of the patients being reviewed. And that enables us to focus valuable attention by focusing the attention on patients that are most at risk, on those patients that require further clinical review and potentially attention, and therefore provide a path to intervening at the patient level, as well as, of course, identifying patterns of harm that might be occurring across the population. Automated workflows and the health IT aspect of it result in a more manageable amount of clinical review, enabling the process to remain highly scalable. And it's really important to point this out because the clinical review process across safety, quality, and risk areas is critical to produce learning that would otherwise not occur. In short, clinical judgment is irreplaceable in adverse event management. But how do we combine that with automation to make it scalable and to learn more faster and more effectively? Next. One of the reasons why we can learn faster and more effectively is the real-time aspect of it all. And one might ask, well, what does that really mean? Next. First, if we can tap into more types of data, we can be sort of touching the elephant in more places, if you will, to get a better idea of what the truth is and increase the accuracy of our measurement. Next. Second, if we're tapping into EHRs and other health IT data in real time, we're able to take action and intervene almost immediately. Next. If we can take action, we can also reduce harm as well as any cost related to that harm. And that means that the sustainability increases and there's a business case. Next. if we are ingressing lots of data and creating large pools of data, we can begin to model it and begin to anticipate events that might happen with predictive models. Next. And then finally, if we're also sharing the data, we're increasing the ability to learn and the productivity of our learning. Next. So just to kind of give a snapshot of what this can look like at the operational level, here we see a slide of harm measurement at the hospital level. Most organizations start their real-time safety journey by measuring all-cause harm. They then quickly collect enough data to allow for measurement not only at the unit level, but they begin to see different patterns that they can use for improvement initiatives, again, both at patient and population levels. Next. The next step is to move from measurement to intervention. And so here we have a dashboard where clinical trigger and harms analytics data can, again, point scarce clinical attention, as I referenced earlier, to specific patients, specific patterns, which then are input into programs on a much faster cycle basis. Next. As we move beyond measurement and monitoring, we begin to press the frontier of prediction. And that's where we can use clinical triggers and other predictors to identify patients before they develop their harm, patients that might be at risk. And so using the power of a very large clinically confirmed adverse event database, a big data predictive analytic program can identify patients at risk before harm occurs. And this is done in a way where the design is to have such a predictive model work across the continuum of care. Currently, it's being tested in the hospital setting, to start with, but it appears to work in multiple settings. It provides yet another perspective of safety, adding yet another lens, which can provide a real-time snapshot on a patient's condition. Next. So all of this really points to value. Next. And, enormous clinical value clearly is a significant opportunity. It really is all about the patient. Next, financial value is a huge opportunity where a number of hospitals and systems working in this area are really seeing material costs associated with adverse events, and in a value-oriented environment, that's ever more important. Next, we're also seeing public announcements from the regulators indicating that the direction is to move safety-related reimbursement increasingly to be tied to electronic measures, even in a fee-for-service environment, as recent announcements have indicated. Next. On the learning system front, if the cost of real-time data is less, which it is, what that means is as we're learning and as the cost of learning goes down, we can expect the productivity of our learning to go up. Next. And just as I said at the outset, it's all about the patient. And if we're identifying more and more harm out there, there's a moral imperative for us to act on that, and there's enormous moral value as well. Next. So just to wrap up, next, as far as future directions, there are three directions that we might reference with respect to measurement, next, improvement, next, and learning. On the measurement side, we will continue to see emerge new sources of data that we can use to understand at a fine-grained level how to measure more efficiently and effectively. On the improvement level, as we have more fine-grained data and analytics, that enables us to conduct more targeted interventions, and with that, more targeted improvement programs. And then finally, on the learning front, the nature and appetite of learning, particularly by patients, we see will only increase as transparency moves more swiftly towards patient safety. Thanks for your attention today, and I'm looking forward to the Q&A session. Back to you, John.
Great. Thank you very much, Drew and Peggy and Ronnie. So we're going to have time now until 2:30 for questions and answers. We've gotten a number of questions that have come in over the chat or the question function, so feel free to send those in, and we will do our best to answer as many of them as we can. And I also just want to point out that the slide showing now has contact information for speakers, and also that we will be having our next webinar in the series a little over a month from now on CPOE, clinical decision support, and health IT safety. Both the two presenters for that will be David Bates and David Klassen, and we'll have more on that coming up in our next invitation. So, so turning now to some of the questions, let me go back to one that came in early, and this one, I guess, is directed to Peggy. PSOs clearly contribute to quality and safety in patient care under a federal mandate, but they haven't always played well with quality improvement organizations and state health departments that are also federally mandated to do similar work under similar protections with provider organizations. The question, what is being done to ensure PSO, QIO, and pertinent state health department programs like HAI, hospital-acquired infections, are all coordinated into guidance so that there's a better evolution of health IT systems?
That is a great point and a great question. You know, when we look back to the purposes and the organizations, they all have a different purpose. The state programs, for example, are meant to be transparent and to improve quality through being transparent and letting everyone know about it. Patient safety organizations are a little bit different. They are intended to allow healthcare professionals to take a hard look at themselves in a safety culture and to implement safety culture. However, the information that we produce is intended to be shared with everyone, and that would include to be shared with QIOs and state health departments, state programs as well. And so what we're attempting to do at the Alliance for Quality Improvement and Patient Safety is work to better align the information and share it throughout the healthcare continuum with everyone who could find the information useful. We also find that QIOs are able to become component PSOs, and over time we have seen some dabble in the patient safety protections and analytic capabilities. And so I also view over time that there's going to be greater movement toward adopting the PSO structure, and so that will also help implement change and coordination throughout the entire healthcare system.
Great, thank you very much, Peggy. And there's looks like almost a follow-up, or at least a related question, which has to do with submitting reports, adverse event reports, to more than one agency. So the question is, if providers have to submit to the PSO, if they're a member of a PSO, and also a state agency because of state mandates, and maybe there are other examples of where there's multiple submission of reports. What's going on to try to make that easier so that providers don't get sort of double or triple tapped?
Sure. There is a lot of reporting that's either required or voluntary through collaboratives and also with a PSO. And what a number of PSOs are doing is allowing the report to go to multiple different places. And so the copy of the report may go to the PSO, the original report may go to the state required reporting or to other sources. So there's a lot of work being done to help folks do that. There's also work being done to pull information like Trigger Tool out of the electronic health record, and that will make life easier for everyone because there won't be any more manual reporting. So there is lots of potential in the future for reporting to be made easier.
Great.
Ronnie, or do you have any, or Drew, do you have any comments?
I think you captured it, Peggy.
Well, Peggy, this is Ronnie. So I agree with Peggy that oftentimes I can say that at ECRI we do get reports that providers have submitted to the state because they want to share them with us and have it be a part of their portrait.
Great. Okay. Well, thank you. So the next couple of questions came in during Ronnie's presentation, and the first one, boy, this one's detailed. So it says, what keywords or phrases have been identified in mining data from help desk reports to best identify safety risks from this non-standard data source?
That's such a great question. And, you know, this is a work in progress. So as I mentioned, unexpectedly, but we're happy about this, we have gotten a pool of help desk tickets. So we're undertaking a little study here where we're looking at that data and using data mining tools to try to figure out which are the important safety topics that are coming up. And what we really like about this is everybody's got help desk tickets. Every institution has this. So if we're able to identify a way to mine that data that already exists, that can really help us take a nice step. We don't have to create a new pot of data to analyze. We can use what's there. This is a work in progress, John, and whoever asked that question, I'd be happy to share with you, some of the phrases and the language and text strings that we're using. We have a couple analysts in our team who are doing that. So I hope that's helpful.
Great.
And then once we get through this exercise, I'm not sure how long it's going to take. If we do find a useful way to get through this, we will publish on it and get the information out there so that other people can use it.
Great. Thank you very much. Drew or Peggy, any other comments? I don't know whether the question about help desk reports is something that you have experience with.
I don't have anything to add, John. I think Ronnie's experience is pretty reflective.
Great. Okay. The next question is, does anyone know the status of the mandate that hospitals of 50 beds or more must be affiliated with a PSO to be involved with insurance exchanges?
Sure, absolutely. In the CMS inpatient rule, there was a section that discussed the implementation of the requirement in the Affordable Care Act that provides that all hospitals over 50 beds must implement a patient safety evaluation system by 2015. CMS looked at this, and it came up so quickly after the passage of the Affordable Care Act that they have provided an extension to 2017. So we'll be waiting to hear the regulatory announcement as that date approaches. And PSOs have been working with providers in anticipation of that requirement to really help them develop their patient safety evaluation system and safety culture to prepare for that requirement.
Great.
John, this is Drew. I'd like to add to Peggy's comment as well. The underlying assumption, I think, in the first question around reporting, as well as this question on the requirement, is that perhaps the value of PSOs is such that providers will only use them if required for the purpose of reporting or to from an insurance exchange requirement standpoint. But what we're finding is there's a lot of cost associated with that preventable harm. And if an adverse event increases the probability of readmission whether 30 days, 90 days, or let's say utilization and outpatient up to a year after discharge. The reality is in a value-driven environment, it's absolutely critical to identify and reduce harm while the patient is in the hospital. Because if we don't do that, then whether you're in an ACO or in a bundling scheme or some type of capitated scheme, or now what we're finding is even in a fee-for-service environment, the economics will deteriorate for that hospital. And so again, because it's the right thing to do, but because it is absolutely critical from a cost standpoint to manage, PSOs can be helpful well beyond any kind of compliance requirements that they need to comply with, and of course, which we're very supportive of, given, I think, the government's increased interest in safety. So the regulatory requirement is key, but there's a huge financial imperative, and finally, there's a clinical imperative for the patient.
And you know, I'm going to comment too. I'm not a real fan of mandates, but we have seen so many providers working with PSOs because there is such great value. And providers can establish their own programs in the patient safety evaluation system, so it really needs to be driven from within. What is keeping your chief medical officer up at night? Where's your CIO seeing the greatest concern, greatest cost drivers? What your nurses see is the most prevalent quality problem or event, and these are all things that the PSO can help you resolve. And also look at the gaps throughout the entire healthcare continuum. We have PSOs who are looking at care that's given in EMS through the emergency room, through intensive care, through long-term care, and how each care impacts the next place, and also to ensure that the transfer happens appropriately and enough communication and data that accompanies that transfer so that the quality of patient care can be maintained. So there's a lot of exciting programs, and I think that what we really need to do is help educate providers on the opportunities that they have rather than focus on a mandate.
If we're conducting population management, but we are not identifying and reducing safety problems, we're missing a huge opportunity.
Great. All right. Well, thank you. Let me add another question into the mix. So this was a question for Ronnie. It says, because ECRI is committed to sharing what it learns, how do you keep the protected space of the PSO separate from the broader sharing in a learning health system?
Yeah, great question. You know, a lot of people think that PSOs hide information, but it's really the opposite. As Peggy outlined, the law is structured to encourage sharing, and I think that it's been successful at that, because PSOs are getting data, but then we got to do stuff with it. We got to try to analyze it. We have to make sense of it. We have to aggregate it. We have to look across organizations and figure out why things happen and get back to people and dig deeper. What we do are a couple of things. One is, of course, we work individually with the organizations who give us data. Of course, that data is identifiable, and it's within that protected space. And what we're prohibited from doing by law is disclosing the identity of the provider, organization, or the identity of the individual provider, of course, the patient. So we work with that individual institution on specific issues, but then we work very hard at aggregating the data, generalizing it, de-identifying it, and publishing stories that are not contextually identifiable, and publish stories that are generalizable so that others can learn. And there's absolutely no prohibition on it. This is the beauty of the PSO law. You share, you can then aggregate, render that data non-identifiable, and then share it more broadly. across really everyone. And there's a lot of information out there in the public sector, and there's certainly a lot on our website, so I'd invite everybody to go on and see it. What we're learning, we're doing our best to share.
Great. I'm going to ask a couple of questions now together, and we'll see if we can answer them quickly. What can a doctor in a small private practice do if not a member of a PSO? That was one of them. Another is, are there any LP-PAC organizations working with PSOs? And the third is kind of related, are physicians aware of whether their medical organization participates with a PSO?
So you've covered the whole continuum of care with that one.
So what can a doctor in a small practice or private practice do?
You know, I think there's a lot of opportunity for physicians in practices, and we've got to find a way to get the word out there. I know that there should be ways to be able to spread PSOs into that setting. We have a lot of physician practices, but a lot of times they're affiliated or owned, you know, by a larger provider, and they come on that way. We have a medical society, for example, that signed up, you know, that got its members involved. But I think it really is difficult. You've brought up a wonderful opportunity there. And maybe some of the professional societies that represent physicians could help get the word out. I think
and a number of the professional societies for medical associations, for example, do have patient safety organizations to work with the small healthcare provider. We can, if the healthcare provider is interested, we can help hook them up with a PSO. And some PSOs don't charge; others charge, you know, relative amounts to, you know, the size of the provider. So I think there's great opportunity in ambulatory care because we have not had a lot of reporting from that sector before. And so right now I do know that there's a number of PSOs that are focusing on ambulatory care and particularly setting up peer programs and also connecting them with all of their folks who they work with, the inpatient world, the labs, and other folks, so that folks can learn how to do transfers better, how to share information better. So there's a lot of work that's being done in that space. So I do encourage independent physician practices to step forward because we'll be glad to help get them connected.
This is Drew, John. I'd agree with Peggy and Ronnie. I mean, the role for the PSO extends across the continuum, and certainly that includes practices. I think, you know, a first step that we're finding the ambulatory and outpatient area doing is measuring the culture of safety in their practices, and that's a great place to start, and we're seeing a lot of success there. Because if it can be identified that there's insufficient psychological safety for caregivers to speak up, that's a great starting point. That extends all the way through to more integrated systems which are tracking safety across the continuum. And so the ability to use, again, in an age of health IT, tools to identify that there is a lack of coordination, or in order to make sure that the information is conveyed from outpatient to inpatient or vice versa, there's a lot of opportunity to leverage some of those tools across the continuum that can really help ambulatory outpatient clinics, and the PSO has a role to play in that.
You know, John, consider one issue, medication reconciliation. Wow, you know, such a big issue that crosses all settings, and it's so tough to get right. And right now, HIT systems are not necessarily talking to each other across those siloed settings, so it's difficult to achieve big leaps.
Yeah. Well, great. Well, I want to close by thanking Peggy, Ronnie, and Drew for really an excellent presentation as well as discussion. We didn't get to all of the questions that came in, but the speakers have agreed to respond to questions if you have them. The email addresses for them are on the screen right now. And I want to thank everyone who participated and listened, and hope that we see you again in a month when we have our next webinar. So with that,